Welcome to the Deep Dive, your personal guide for navigating complex information and really finding those powerful aha moments. We're here to cut through the noise, give you a genuine shortcut to expertise, and help you become truly well-informed, sometimes in pretty surprising ways. Today, we're really going to dig into a fascinating and honestly critical area of cardiovascular health, paroxysmal supraventricular tachycardias. You might hear them called PSVTs. Our source material for this deep dive is Chapter 249, Paroxysmal Supraventricular Tachycardias, right from the foundational Harrison textbook. And this isn't just about skimming the surface, right? We're going all in. The goal is to master this topic like the absolute top professionals in the field.
That's exactly the plan. Our mission today is to, empower you with a deep, really nuanced understanding. We'll meticulously unpack the intricate electrical mechanisms behind these sudden rapid heart rhythms. We'll delve into their diverse clinical presentations and precisely examine the strategies for diagnosis and, importantly, the cutting-edge treatments. It's really about grasping not just what these arrhythmias are, but how they work, why they matter, and, what that ultimately means for patient care.
So if you've ever wondered about those sudden kind of alarming heart palpitations or wanted to truly grasp the complex dance of electrical pathways in the heart and maybe figure out what really sets different fast heart rhythms apart, then get ready. We're going to give you that shortcut to genuine mastery, revealing one fascinating fact at a time. Let's start by setting the stage for our deep dive. Okay, let's start with the basics. Because that term, supraventricular tachycardia, SVT, it sounds incredibly broad, doesn't it? Almost like a catch-all for anything fast starting above the ventricles. What precisely are we talking about when we say SVT, and how does Chapter 249 narrow that definition for our focus today?
That's a really crucial distinction to make right off the bat. You've hit on a key point immediately. While, yes, the umbrella term SVT technically covers a very broad group of tachyarrhythmias, meaning rapid heart rhythms originating above the ventricles. So that includes things like sinus tachycardia, which can be normal, or atrial tachycardia, AT, atrial flutter, atrial fibrillation. Our focus for this specific deep dive, looking at Chapter 249, is much, much more refined. We're specifically discussing a particular subset. These are sustained SVTs that are fundamentally dependent on the atrioventricular node, the AV node. Think of the AV node as the heart's natural electrical gatekeeper, or maybe a traffic controller, right? It sits between the atria, the upper chambers, and the ventricles, the lower chambers. So this chapter really zeroes in on providing a highly organized approach to diagnosing and treating these particular AV nodal-dependent SVTs. It acknowledges that other really critical and complex SVTs that are not AV nodal dependent, like atrial flutter or AFib, they're discussed extensively elsewhere in the textbook. Yeah, so that tells us their mechanisms and their management strategies are distinct enough to warrant their own separate, in-depth discussions. So think of this deep dive as focusing on a very specific yet incredibly common and clinically important set of rapid heart rhythms where that AV node is the absolute central player.
Okay, so we're really narrowing our lens, focusing right in on this specific set of high-speed heart rhythms that have this critical reliance on the AV node, that electrical gatekeeper.
Right.
Within this AV nodal-dependent group, then, what are the key players, the main characters we're going to be focusing on today?
Exactly. Within this chapter, the primary focus includes 4 main categories. These really represent the core of these AV nodal-dependent tachycardias. First, and arguably the most common one we see, is atrioventricular nodal reentry tachycardia. We'll just call it AVNRT for short.
AVNRT.
Got it. Yeah. This is a rhythm where the electrical impulse basically gets caught in a continuous loop within or immediately around the AV node itself. It's like a classic electrical short circuit. Second, we have junctional tachycardia, or JT. This refers to a rapid rhythm that originates from the AV junctional tissue itself. But it's not due to a loop like AVNRT. It's due to abnormal automaticity. Essentially, that area of the heart just starts spontaneously firing off impulses way too quickly on its own.
Like it's overly excited.
Exactly, overly excited and firing too fast. Then third is atrioventricular reciprocating tachycardia, or AVRT. Now, this type specifically utilizes an accessory pathway. This means there's an extra abnormal electrical connection directly linking the atria and ventricles, and it completely bypasses the normal AV node. The arrhythmia relies on this pathway as part of its circuit.
So a literal bypass road.
Literal bypass road, exactly. And finally, there's a sort of broader group of pre-excited tachycardias that also involve an accessory pathway. These are a little different because the accessory pathway is actively involved in driving the ventricular activation in a rapid and potentially very dangerous way.
Okay, let's unpack this. This is where the electrical puzzles really start to emerge, isn't it? It gets incredibly interesting. Let's dive into each of these, starting with what sounds like the most common one, AVNRT. So AVNRT, you said it's the most common form of PSVT. The chapter notes it makes up about 60% of cases referred for catheter ablation. What does that staggering statistic immediately tell us about its clinical impact? I mean, the burden it places on patients and the healthcare system must be huge.
Oh, absolutely. It tells us AVNRT is an extremely significant clinical entity, something clinicians encounter really regularly. And while, many individuals can tolerate an episode relatively well, especially if they're younger, its sheer frequency means it accounts for a very large burden of symptoms on a population level. Think about it. 6 out of 10 people needing a specialized procedure like ablation for a rapid heart rhythm.
Yeah.
That points to a really widespread issue.
Yeah, that's a lot.
It is. And these symptoms, they can range from just bothersome palpitations, that feeling like your heart is jumping out of your chest, to really severe, debilitating episodes that significantly impact a person's quality of life, often sending them straight to the emergency room, seeking urgent medical attention.
And who typically experiences AVNRT? Are there any common demographic patterns or maybe predispositions we should know about?
Yeah, there are some patterns. It most commonly manifests in individuals during their second to fourth decades of life. So think 20s through 40s typically. And interestingly, it's often seen more frequently in women. That's a demographic characteristic worth noting, although the exact reasons why aren't fully understood. But importantly, and this is a key differentiator from some other arrhythmias we'll talk about, AVNRT is generally not associated with underlying structural heart disease.
Okay, so the heart muscle itself is usually fine.
Usually, yes. The heart muscle itself, its chambers, its valves, they're typically structurally normal. The problem isn't the heart's plumbing or walls, it's the wiring, the electrical system.
So if it's not usually tied to underlying heart disease, is it considered life-threatening? Can
Okay.
people just live with it, or can it still cause serious problems?
That's a really important question. In patients without associated structural heart disease, AVNRT itself isn't typically considered life-threatening. However, that absolutely doesn't mean it's benign or just something to, live with. It can cause very significant and distressing symptoms. Just imagine your heart suddenly beating at an extremely rapid rate,
Yeah.
sometimes 180, 200 beats per minute, maybe even faster. Yeah. That rapid tachycardia, particularly in older individuals, or maybe those with even mild underlying conditions like coronary artery disease or high blood pressure, it can precipitate serious issues. Things like angina or chest pain because the heart just isn't getting enough oxygen at that speed, or pulmonary edema that's fluid buildup in the lungs, making it hard to breathe, hypotension, meaning dangerously low blood pressure, causing severe dizziness, lightheadedness, or even syncope, fainting. So while it might not be inherently deadly in a structurally healthy heart, its rapid nature can certainly trigger acute and serious complications that need urgent medical help.
Okay, this is where the true electrical puzzle of the heart really unfolds for me. How does this re-entry mechanism actually work within the AV node? It's fascinating to think of an electrical signal just getting caught in a continuous loop like that.
It really is fascinating, and this is the absolute core of AVNRT. It's a brilliant example of how complex, yet sometimes subtle electrical pathways can create this persistent, rapid loop. The fundamental mechanism is reentry, specifically involving the AV node itself and the surrounding paranodal atrium, that's the atrial tissue immediately next to the AV node. This intricate electrical dance is made possible because there are multiple pathways for electrical conduction from the atrium into the AV node. And crucially, these pathways aren't just parallel routes, they possess different electrophysiological properties, especially regarding their speed of conduction and their refractory periods.
Refractory periods like a recovery time.
Exactly, how quickly they can recover and be ready for the next electrical impulse. These differences in speed and recovery time set the stage for a circular flow. To help illustrate this, think of it like a stretch of highway. You've got a main, fast lane, and right next to it, there's a parallel, slower service road.
Okay, I can picture that.
And both lanes eventually merge back together. Now, normally, the electrical impulse in the heart travels down the fastest route available, right? The fast lane. But under certain conditions, like a premature atrial beat, an early beat coming from the top chambers, the impulse can find itself blocked in the fast lane because it hasn't recovered yet.
Oh.
But the slow lane, the service road, has recovered, so the impulse gets diverted down the slow pathway.
Well,
And by the time it reaches the end of that slow pathway, the fast pathway has now had time to recover, so the impulse can then travel backwards up the fast pathway to re-excite the area near the beginning of the slow pathway.
creating the loop.
Precisely. It gets caught in this continuous loop, cycling down the slow path and up the fast path over and over again. This is the typical form of AVNRT, often called slow-fast AVNRT, and it accounts for the vast majority of cases, over 90%. That slow pathway or service road is usually a right inferior extension from the compact AV node itself near the His bundle. It extends down along the tricuspid valve annulus, the ring around the valve, towards the floor of the coronary sinus. So during initiation, that premature beat goes down the slow path, then up the recovered fast path to the compact AV node, activating the His-Purkinje system and ventricles normally. And the path back to re-enter the slow pathway usually involves the left atrial septum, which has connections to the coronary sinus musculature. So down slow, up fast, activate everything, loop back to slow. A continuous, rapid, self-sustaining circuit.
Wow, that highway analogy really helps visualize it.
It does, doesn't it? Now, while that typical slow-fast form is most common, there are variations, though they are much rarer. For instance, some forms might use a left inferior extension connecting through the roof of the coronary sinus. Or, in extremely rare cases, they can go directly from the mitral valve annulus, completely bypassing the coronary sinus musculature. But the fundamental principle is always the same. A reentrant loop, depending on at least two distinct conduction pathways in that AV nodal region, with different conduction speeds and recovery times.
That's a very clear and intricate picture of how that loop gets established. Now let's look at the ECG, those electrical squiggly lines that tell the heart's story. How do we identify this specific type of tachycardia? What are the electrical signatures a clinician would look for to say, that looks like AVNRT?
Right, the ECG is our primary diagnostic tool here. And it can be tricky because in typical AVNRT, the atrial activation happens at almost the exact same time as the ventricular activation. So the P wave, which represents atrial activity, is often inscribed during or maybe slightly before or slightly after the QRS complex, which represents ventricular activity. This close timing, almost simultaneous, makes it quite challenging to clearly see the P wave on a standard ECG. It often gets hidden or buried within the QRS or right at the beginning of the ST segment.
It's all subtle.
Very subtle. But for the trained eye, there are key ECG clues that skilled clinicians meticulously look for. Often you'll see the P wave appearing right at the very end of the QRS complex. It gives a characteristic subtle distortion to the QRS shape. This might show up as what's called a pseudo-R in lid view 1. It looks like an extra little upward bumper notch at the end of the R wave, almost like the QRS has an extra little tail. And at the same time, you might see pseudo-S waves in leads 2, 3, and AVF. These are small, distinct downward deflections or notches right at the very end of the QRS in those leads. These subtle changes, almost like an echo tacked onto the end of the QRS, are often the dead giveaway for typical AVNRT. They represent that simultaneous or near simultaneous retrograde atrial activation.
Pseudo-R prime and pseudo-S waves. Got it.
Exactly. Now, in the more unusual forms of AVNRT, where the P waves fall later, maybe somewhere between the QRS complexes, you might see a different pattern. In these less common cases, you could see an inverted P wave in the inferior limb leads 2, 3, and AVF. Sometimes it's even inscribed within the subsequent T wave, making the T wave look notched or distorted. So while typical AVNRT has these very specific, though subtle ECG characteristics that need careful inspection, the rarer forms can present a bit differently, demanding a really keen and experienced eye.
Beyond the ECG, how does this rapid heart rate manifest in the body? What physical sensations or unique signs might a patient experience that point directly to AVNRT? Sounds like there's some very specific clinical pearls here.
There are indeed a couple of classic symptoms, really specific to AVNRT, directly linked to the unique mechanics of this particular reentry circuit. The heart rate itself, well, it can vary significantly with sympathetic tone, stress, anxiety, physical exertion, caffeine. These can all make the tachycardia faster because they influence the conduction time through those AV nodal tissues. But one very common and distinct symptom, almost a diagnostic giveaway if you see or hear about it, is due to that simultaneous contraction of the atria and ventricles we mentioned.
Right, fighting against each other.
Exactly. Because the atria are contracting forcefully against a closed tricuspid valve. Imagine trying to push water into a pipe with the valve shut tight. It produces a distinct phenomenon called a cannon wave. This is a large, forceful pulsation that you can sometimes actually see in the jugular venous pulse in the neck. You might see the patient's neck veins visibly thump with each beat.
Wow, really?
Yeah. And this is often perceived by the patient as a powerful, uncomfortable fluttering sensation in the neck, or even a pounding sensation in their ears. It's a direct result of that synchronized but inefficient atrial contraction. Additionally, these elevated venous pressures, caused by the atrial contraction against the closed valve, can trigger the release of natriuretic peptides,
Hormones, right.
hormones that regulate fluid balance. Their release in this context causes a common symptom known as post-tachycardia diuresis. This means increased urination shortly after an episode of tachycardia terminates. The body is trying to shed fluid in response to what it perceived as a transient fluid overload.
So they have an episode, it stops, and then they suddenly really need to pee.
Exactly. So a patient might report a sudden urge to urinate shortly after their rapid heart rate stops. These two signs, the cannon wave or neck fluttering, and this post-tachycardia diuresis, are incredibly specific and helpful diagnostic clues for AVNRT.
Those are very specific and helpful clues, almost like the body's giving us a secret handshake for this particular arrhythmia. What's the immediate treatment approach, then, for an acute episode of AVNRT? And how does it specifically differ from other arrhythmias we might encounter?
Okay, so a key distinguishing feature of AVNRT, especially when you compare it to other types like atrial tachycardias or atrial flutter, is that maneuvers or medications that produce AV nodal block will reliably terminate the arrhythmia.
Because the node is essential for the loop.
Precisely. Since the AV node is a crucial, indispensable part of that reentry circuit, blocking conduction through it effectively breaks the loop, like cutting a wire in a faulty circuit. This means the acute treatment for AVNRT is generally the same as for other forms of PSVT that are also AV nodal dependent, like orthodromic AVRT. We'll discuss the general acute management strategies in more detail shortly, but the principle is key. Target the AV node to break the circuit. That's the Achilles heel of AVNRT.
And for long-term management, if someone has recurrent episodes and it's really impacting their life, what are the options? Are they always stuck with medication, or is there something more definitive?
For long-term management, whether ongoing therapy is needed really depends heavily on two crucial factors: how severe the symptoms are for the patient and how frequently the episodes occur. For many patients, especially if episodes are infrequent, not too rapid, and they tolerate them well, simple reassurance and clear instruction on how to perform the Valsalva maneuver or other vagal nerve stimulating maneuvers can be enough.
So they can try to stop it themselves.
Exactly. These maneuvers increase vagal tone, which slows down AV nodal conduction, making it harder for the reentry circuit to keep going, and often it can break the circuit entirely. Giving patients this self-management tool is really empowering. However, for those with more recurrent, bothersome, or even debilitating cases, that's where pharmacological options come into play. Beta blockers are a common first choice, as are calcium channel blockers like diltiazem or verapamil. These medications work primarily by slowing conduction through the AV node, making it harder for that reentry circuit to initiate or sustain itself. Additionally, some antiarrhythmic drugs like flecainide, propafenone, disopyramide, sotalol, and even amiodarone, can also be effective in reducing the frequency or severity of episodes. It's crucial, though, to always consider their potential toxicities and adverse effects. Many of these antiarrhythmics have significant side effects or require careful monitoring, which often means we try to avoid using them long-term unless absolutely necessary.
Right, balancing the risk and benefits.
Always. It's about balancing symptom control against potential drug-related complications for each individual patient. But the truly curative option, often considered the gold standard for many patients, is catheter ablation.
Ah, the procedure you mentioned earlier.
Exactly. Specifically, catheter ablation targeting that slow AV nodal pathway is the recommended definitive treatment for patients with recurrent or severe episodes, or when drug therapy is ineffective, not tolerated, or simply not desired by the patient who just wants a permanent solution. This procedure is remarkably curative. Success rates are over 95%.
That's incredible.
It really is. During the procedure, a tiny area of that slow pathway, the one crucial for the reentry circuit, is precisely targeted and ablated, usually using radiofrequency energy or sometimes cryoablation, freezing it. This effectively eliminates the electrical path needed for the arrhythmia. The major risk, though thankfully small, is accidentally causing complete AV block, which would then require a permanent pacemaker. But that happens in less than 1% of patients. So this very high success rate, combined with a low serious complication rate, is why ablation is often preferred for those seeking a definitive solution and freedom from recurrent symptoms and medications.
That's an incredibly high success rate for a procedure that can truly change someone's life. Okay, moving on to another type, What is junctional tachycardia, or JET? How does it differ fundamentally from AVNRT, and who is typically affected by it? You mentioned it was rarer.
Yeah. Junctional ectopic tachycardia, or JT, is definitely rarer and fundamentally different from AVNRT in its mechanism. While AVNRT is that reentry rhythm, the electrical loop, JET is primarily due to abnormal automaticity within the AV node itself, or the immediately surrounding junctional tissue.
Automaticity,
Yeah.
meaning it just fires on its own.
Exactly. It means a specific focus, a small group of cells within this tissue, spontaneously starts generating electrical impulses at a rapid rate. It essentially takes over the heart's pacing function from the normal sinus node. It's like an alarm bell suddenly ringing way too fast all by itself. As for who gets it, it's quite rare in adults. JET is much more frequently encountered as an incessant or nearly continuous tachycardia in children. Particularly, it's often observed in the perioperative period, meaning right after surgery for congenital heart disease.
So after fixing structural problems, this electrical issue can pop up.
Exactly. Imagine a child recovering from complex heart surgery. JUT can be a significant post-surgical complication that requires careful management in these young, vulnerable patients. In adults, when it does occur, it's often associated with acute conditions or specific triggers rather than being a chronic issue.
And how does it present on an ECG, for instance? And what might trigger it in adults or kids?
It typically presents as a narrow QRS tachycardia on the ECG, similar to AVNRT in that aspect, because the impulses are still conducted down the normal His-Purkinje system to the ventricles. However, a key distinguishing feature, especially in more severe cases, is that it often presents with ventricular atrial block, or VA block.
Meaning the top and bottom chambers are out of sync.
Precisely. There's AV dissociation. The atria and ventricles are essentially beating independently of each other, or at least not in a coordinated one-to-one fashion. That automatic focus in the AV junction is driving the ventricles rapidly, while the atria might be doing their own thing, maybe driven by the sinus node, or maybe getting occasional retrograde signals, but not consistently linked. As for triggers, JET can sometimes occur just as a manifestation of increased adrenergic tone, meaning the body's sympathetic nervous system, the fight or flight system, is highly activated. You might see it, for example, after giving drugs like isoproterenol, which is a beta agonist that directly ramps up sympathetic activity. It can also occur, maybe more commonly in adults, after catheter ablation procedures in that paranodal region. Irritation or maybe minor injury to the AV nodal area during a procedure can sometimes trigger this abnormal automaticity. And similarly, it might pop up for a short period right after an ablation for AVNRT, again, potentially due to transient irritation or inflammation in the area.
What about accelerated junctional rhythm? Is that the same thing, or is it like a milder version clinicians should know about?
Good question. Accelerated junctional rhythm is related, but it's a distinct concept. It also refers to a junctional automatic rhythm, so the same mechanism, but importantly, its rate is slower. It's between 50 and 100 beats per minute.
So faster than normal backup rhythm, but not quite tachycardia.
Exactly. It's faster than a typical junctional escape rhythm, which is usually under 50 BPM, but slower than what we usually call tachycardia, which is typically over 100 BPM. Its initiation might involve a gradual acceleration in rate, which strongly suggests that automatic focus is just slowly speeding up. Or, alternatively, it could follow something like a premature ventricular contraction, which might indicate a focus of triggered automaticity, meaning it needed a little trigger to get started, rather than just pure automatic firing. In accelerated junctional rhythm, VA conduction is usually present, meaning the ventricles do conduct back to activate the atria. And the P-wave morphology and timing can actually look a bit like AVNRT, just at a much slower rate. Like JET, it can be related to increased synthetic tone and might cause palpitations, but it's typically less rapid and often transient. Because of its usually benign nature and slower rate, it usually doesn't require specific therapy. It's more often just an observation, something to note that often resolves on its own.
Okay, now this is where it truly gets mind-bending for me, and honestly one of the most fascinating parts of cardiac electrophysiology. Let's talk about accessory pathways. You call them electrical detours or secret bypass roads in the heart. That concept just immediately sparks curiosity about how the heart's incredibly intricate wiring can, well, go awry like that.
That's an excellent analogy. Electrical detours or bypass roads captures it perfectly. Accessory pathways or APs are truly abnormal congenital connections. They're there from birth. They allow electrical conduction directly between the atrium and ventricles, but crucially, they completely bypass the normal AV ring and the specialized AV node and his Purkinje system. They essentially create a short circuit that lets electricity flow outside the normal, controlled, regulated pathways.
And they're not super rare. You said 1 in 1,500 or 2,000 people?
Yeah, not incredibly rare, certainly common enough that clinicians encounter them. They are present from birth, essentially due to a developmental anomaly. It's like a failure of complete partitioning of the atrium and ventricle by those fibrous AV rings during normal heart development in the embryo. A small muscular connection persists when it shouldn't have.
And these pathways are associated with a whole range of arrhythmias, not just one type.
Yeah.
And even though rarely, sudden death, that sounds incredibly serious, especially given they're there from birth.
Precisely. The presence of an accessory pathway is indeed linked to a wide variety of arrhythmias, both narrow complex PSVTs, like the orthodromic AVRT we'll get to, and also wide complex tachycardias, like antidromic AVRT, or most dangerously pre-excited atrial fibrillation. And yes, while thankfully rare, they are indeed associated with sudden death. That's the most feared complication, particularly in certain high-risk scenarios we absolutely need to delve into shortly. Now, while most patients with APs do have structurally normal hearts otherwise, these pathways are also known to be associated with specific congenital heart defects or cardiomyopathies. Our source mentions conditions like Ebstein's anomaly of the tricuspid valve. That's a malformation where the tricuspid valve leaflets are displaced down into the right ventricle, and also certain forms of hypertrophic cardiomyopathy, including those linked to specific genetic mutations like PRKG2 mutations, Danon disease, and Fabry's disease.
So finding an AP means you should probably look for these other things too.
Absolutely. While often it's an isolated finding, it's crucial for clinicians to consider and often rule out these associated conditions, as they can significantly alter the overall management plan and the patient's risk assessment. It adds another layer of complexity.
Where do these abnormal connections typically pop up in the heart? Are they randomly distributed, or are there common hot spots where these electrical detours are usually found?
They're not completely random. There are definite hotspots. They can occur across either an AV valve annulus, meaning that fibrous ring separating the atria and ventricles, around the mitral valve on the left or the tricuspid valve on the right, or they can occur across the septum, which is the wall dividing the heart's left and right chambers. The most frequent locations by far are between the left atrium and the free wall of the left ventricle. That's the most common spot.
Okay, left free wall.
Yeah. Following that, in terms of frequency, are post-receptal locations sort of at the back part of the septum, then the right free wall, and finally anteroceptal locations at the front of the septum. And the specific anatomical location of the pathway has really important implications for how the heart's electricity behaves, what the ECG might reveal, and even how an ablation procedure might be approached. Location matters a lot.
So, if electricity takes this detour through an accessory pathway, what does that look like on an ECG? How do these detours manifest as distinct electrical signatures? This concept of pre-excitation sounds like the key here.
It absolutely is the key. Pre-excitation is the hallmark of an accessory pathway on an ECG, provided it's actively conducting in the forward or antegrade direction. So if the electrical impulse coming from the sinus node, the heart's natural pacemaker, conducts through that accessory pathway to the ventricle before the impulse conducts through the normal, slower AV node and his Purkinje system, then a portion of the ventricles gets activated prematurely. We call this pre-excited during normal sinus rhythm. Essentially, a small part of the ventricle gets an early, kind of messy start via that direct AP connection before the main signal arrives.
And what does that messy start look like on the ECG?
Okay, the ECG hallmarks of pre-excitation are quite distinct, and once you learn them, they become pretty clear indicators. First, you'll typically see a short PR interval, usually less than 0.12 seconds. This is because the atrial impulse reaches the ventricle faster than normal, bypassing that physiological delay built into the AV node.
Haircut means shorter time. Makes sense.
Exactly. Second, and perhaps the most characteristic sign, is a delta wave. This is a slurred, slow initial portion of the QRS complex. It looks like the QRS doesn't take off sharply, but rather ramps up slowly at the beginning. This slurring represents the slower direct activation of the ventricular myocardium over the accessory pathway, happening outside the fast, specialized His-Purkinje conduction system. And third, because of the slower initial conduction over the AP, you'll also usually see a prolonged QRS duration. The QRS complex appears wider than normal overall. This widening is produced by the fusion of that slow activation via the AP and the later faster activation via the normal His-Purkinje system.
Short PR, delta wave, wide QRS, the trifecta.
That's the classic trifecta of manifest pre-excitation, yes. Now, the specific morphology, the shape of that QRS and the delta wave can actually give us critical clues about the accessory pathway's location, and also about the degree of fusion, how much of the ventricle is activated by the AP versus the normal system. For example, if you see a right-sided pathway, it'll pre-excite the right ventricle first. This often produces a left bundle branch block-like configuration in lead V1 on the ECG, meaning the main electrical forces look like they're moving leftward. These right-sided pathways can sometimes create marked pre-excitation, a very obvious delta wave, because the accessory pathway might be relatively close to the sinus node, leading to very early ventricular activation.
Okay. What about left-sided ones?
Left-sided pathways, well, they pre-excite the left ventricle first. They might produce a right bundle branch-like configuration in lead V1, and interestingly, they often show a negative delta wave in lead AVL. This indicates that the initial depolarization is heading away from that lead, activating the lateral part of the left ventricle first. This can sometimes be a diagnostic trap because these negative delta waves, these initial negative deflections, can actually mimic the Q waves you see in a lateral wall myocardial infarction, a heart attack.
Oh, wow. That's a serious potential misdiagnosis.
Absolutely. Recognizing these specific patterns is crucial to avoid misdiagnosis. And interestingly, because of the relatively larger distance, the impulse has to travel from the sinus node to reach those left free wall accessory pathways. The pre-excitation might actually be minimal or even completely absent on a standard 12-lead ECG, even if the pathway is capable of conduction. These can be subtle, or what we call concealed antegrade pathways.
Making them harder to spot.
Much harder to spot in sinus rhythm, yeah. Furthermore, pathways down at the diaphragmatic surface of the heart, typically in the paraseptal region, they produce delta waves that are negative in leads THR and AVF. And again, this can mimic the Q waves of an inferior wall infarction, another potential diagnostic pitfall. So, location really dictates the ECG appearance. Another really interesting point, pre-excitation can be intermittent. It might show up on one ECG and not another, or it might even completely disappear during exercise.
Why during exercise?
Because as your heart rate increases with exertion, conduction over the normal AV node naturally speeds up significantly. It becomes more efficient. And it can effectively take over ventricular activation completely, essentially outcompeting the accessory pathway for a period, making the delta wave vanish temporarily. This phenomenon can make diagnosis tricky if the ECG is only captured at rest, and it also highlights why non-invasive tests aren't always definitive for risk assessment, something we'll definitely come back to.
So given all these nuances, the ECG patterns, the intermittency, the potential for misdiagnosis, when does having an accessory pathway officially become Wolff-Parkinson-White syndrome? It sounds like there's a very specific set of criteria that defines the actual syndrome.
You're absolutely right. There's a precise clinical definition. Wolff-Parkinson-White, or WPW syndrome, is specifically defined as having both of these things. One, a pre-excited QRS during sinus rhythm, meaning those ECG hallmarks like a short PR interval and a delta wave are clearly present when the heart is beating normally. And two, crucially, the patient experiences actual episodes of PSVT. They have documented tachycardia.
So it's the ECG pattern plus the arrhythmia symptom.
Exactly. It's the combination of that distinctive ECG pattern plus the clinical symptom of having the arrhythmia. Many people can have an accessory pathway, maybe even with subtle pre-excitation, but never develop symptoms or arrhythmias. In those cases, they don't have WPW syndrome. The syndrome implies clinical significance, the presence of arrhythmias related to the pathway.
Are there other variations of these accessory pathways that don't quite fit that typical WPW picture? Maybe they don't cause pre-excitation, or they connect different parts of the conduction system. It seems like these detours come in several different forms.
Absolutely. The world of accessory pathways is quite diverse, and there are definitely a number of variations that might not cause the typical pre-excitation on a resting ECG, or might not even cause arrhythmias at all, despite having an abnormal connection. First, we have concealed accessory pathways. These are really interesting because they only allow retrograde conduction.
Backward only.
Backward only, exactly. They can conduct electrical impulses only from the ventricle back to the atrium because they don't conduct forward from atrium to ventricle. There's no pre-excitation visible during sinus rhythm. The normal AV nodal pathway handles all the forward conduction. However, these concealed pathways are still clinically very important because they can absolutely be responsible for SVT, specifically orthodromic AVRT, which we'll talk about next. They can still form the retrograde limb, the up direction of re-entry circuit. The impulse goes down the normal way, then back up this hidden backward pathway.
So they're hidden on the resting ECG, but can still cause trouble.
Precisely. Then there are fascicular-ventricular connections. These are unusual connections between the His bundle itself, which is part of the normal conduction system below the AV node, and the ventricular septum, the muscle wall. Now, these do produce pre-excitation on the ECG because they activate a part of the ventricle early, but they typically do not cause arrhythmia. Why not? Well, it's likely because the electrical circuit they form is anatomically just too short to allow sustained reentry. The impulse just moves too quickly through that short loop to establish a stable, ongoing tachycardia. So they're often more of an electrical curiosity and ECG finding than a clinical problem.
Interesting. Any others?
Yes, one more important group. Atriofascicular pathways, sometimes known as Mannheim fibers. These are thought to represent a sort of duplicate AV node and his Purkinje system, almost like an extra conduction system on the side. They typically connect the right atrium directly to fascicles of the right bundle branch, further down the conduction system. Clinically, they usually produce a wide, complex tachycardia that has a left bundle branch block configuration on the ECG, which can be confusing and look like other things. So while they are indeed accessory pathways, their unique anatomical connection point and conduction properties give rise to a distinct clinical and ECG presentation compared to the more common AV bypass tracts. These variations really highlight the diverse ways these congenital connections can manifest and underscore the importance of precise diagnosis, often needing specialized testing.
Okay, let's now talk about the most common tachycardia directly caused by an accessory pathway. This is where the pathway isn't just a bystander or hidden, but an active, indispensable participant in the rapid rhythm.
Right. That would be orthodromic AV reciprocating tachycardia, usually just shortened to orthodromic AVRT. This is, by far, the most common form of tachycardia caused by an accessory pathway. In this rhythm, the circulating reentry wavefront propagates anterogradely, meaning forward, over the normal AV node and his Purkinje system to activate the ventricles.
So down the normal highway.
Down the normal highway, exactly. Electricity takes a controlled route to the lower chambers. Then, after activating the ventricles, it re-enters the atria via retrograde conduction, backward conduction over the accessory pathway. That completes the loop and sustains the rapid rhythm. You can visualize it as a continuous electrical flow down the normal pathway, then back up the accessory pathway, forming this giant, persistent loop involving both the normal system and the bypass tract.
And what does this specific pattern look like on an ECG? How would a clinician recognize this particular form of AVRT?
Okay, during orthodromic AVRT, the QRS complex is typically narrow. That's because the ventricular activation is happening normally and rapidly through the Purkinje system, just like in a normal heartbeat. Now, sometimes it might show a typical right or left bundle branch block pattern if there's a pre-existing block or maybe a related block in one of those bundle branches, but the underlying mechanism uses the normal path down. Crucially, and this is a key point for differentiation, there is no pre-excitation present during the tachycardia itself, even if the patient has obvious pre-excitation, like a delta wave, in their normal sinus rhythm ECG.
Why is that?
Because during orthodromic AVRT, the antegrade activation, the down signal, is exclusively going through the normal AV node and his system, not the accessory pathway. The AP is only being used for the up or retrograde part of the circuit. And since excitation through both the AV node down and the accessory pathway up are necessary for this specific circuit to keep going, any block in either pathway, AV block or VA block, will result in tachycardia termination. It breaks the loop.
Got it. Both parts are needed.
Exactly. Now, if the accessory pathway also allows for antegrade conduction, then yes, you would see pre-excitation during normal sinus rhythm, like we discussed. But during the tachycardia itself, the RP interval, that's the time from the R wave of the QRS complex to the subsequent P waves representing atrial activation, is usually shorter than the PR interval. The specific timing of the P wave relative to the QRS can sometimes make the ECG look a bit like AVNRT, posing a diagnostic challenge, as both can have narrow QRS complexes and P waves that seem to follow the QRS.
So how do we reliably tell it apart from AVNRT, especially if they can look similar on the ECG? This seems like a critical distinction to make for choosing the right treatment, like ablation targeting.
It is a critical distinction, absolutely. And it's where careful, nuanced ECG interpretation is vital, though sometimes it really requires an invasive study to be certain. The fundamental difference often lies in the P-wave timing relative to the QRS. Unlike typical AVNRT, in orthodromic AVRT, the P waves always follow the QRS complex and are never simultaneous with the narrow QRS.
Always after.
Always after. There's a physiological reason for this. The ventricles must be activated before the reentry wavefront can travel across the accessory pathway and conduct back to the atrium to create the P wave. So you'll see the QRS first, then a distinct, though often subtle, P wave frequently tucked into the ST segment or T wave. In typical AVNRT, remember, the atrial and ventricular activations are nearly simultaneous, often burying the P wave within the QRS or making it look like that pseudo-SI or pseudo-S wave right at the end. The morphology or shape of the P wave in AVRT also provides clues, as its shape is determined by where the accessory pathway connects to the atrium. However, it can often be difficult to assess definitively from the surface ECG because it's usually small and distorted by the preceding T wave. For example, posterior-septal accessory pathways typically produce a P wave that's negative or inverted and leads to 3 in AVF. This might appear superficially similar to what you sometimes see in atypical AV nodal reentry, but the overall P wave morphology and its precise relationship to the QRS differs for pathways in other locations, like left free wall or right free wall pathways. An experienced electrophysiologist can often pick up these subtle differences, but yeah, sometimes you need that invasive EP study.
What happens if the accessory pathway conducts really, really slowly in that backward direction? Does that change the clinical picture or the implications for the patient? It sounds like even a slow detour could still be problematic.
Oh, that's a fascinating and extremely important scenario. It leads to a particularly challenging type of arrhythmia. Occasionally, an accessory pathway conducts extremely slowly in the retrograde direction. It takes a very long time for the electrical impulse to travel backward from the ventricle to the atrium via the AP. This results in a tachycardia with a very long RP interval, a significant delay between the ventricular beat, R wave, and the atrial activation, P wave, that follows it. Now, paradoxically, this very slow accessory pathway conduction actually facilitates reentry. It makes it easier for the loop to sustain itself, often leading to a nearly incessant or continuous tachycardia.
Incessant, like it doesn't stop.
Pretty much. It can go on for hours, days, even longer sometimes. This specific type of orthodromic AVRT with a very slow retrograde pathway is known as permanent junctional reciprocating tachycardia, or PJRT. These slow pathways are typically located in the posterior-septal region and, like some other retrograde pathways, often have negative P waves and leads to 3 in AVF. The really serious implication of PJRT is precisely its incessant nature. Because the heart is beating rapidly almost constantly, hour after hour, day after day, it can lead to something called tachycardia-induced cardiomyopathy.
The heart muscle gets weak from overwork.
Exactly. It's a weakening and often dilation of the heart muscle simply due to the chronic, unrelenting, rapid beating. Over time, this can lead to symptoms of heart failure, shortness of breath, fatigue, swelling. And PJRT can be quite challenging to distinguish from atypical AV nodal reentry or even some atrial tachycardias just based on the surface ECG. It often requires that invasive electrophysiology study to definitively map the circuits and confirm the diagnosis. Its incessant nature makes it a particularly high-risk scenario for long-term cardiac damage, really underscoring the need for accurate diagnosis and prompt treatment, usually ablation.
Okay, now let's turn to the pre-excited tachycardias. This is where the accessory pathway isn't just a retrograde detour, but is actively involved in driving the rapid heart rate in the forward direction. This sounds like a potentially much more dangerous scenario, maybe a true electrical free-for-all in the ventricles.
Yes, you're absolutely right to flag this as potentially more dangerous. These cases can be particularly perilous and demand immediate recognition and appropriate management. In pre-excited tachycardias, the ventricles are activated, at least in part, by antegrade conduction over the accessory pathway. The impulse travels directly forward through that abnormal connection to the ventricles. The most common mechanism for this involving a reentry circuit is antidromic AV reciprocating tachycardia, antidromic AVRT.
Antidromic, meaning against the usual way.
Kind of, yeah. It's the opposite of orthodromic. In this scenario, activation propagates from the atrium down to the ventricle via the accessory pathway, that's the antegrade conduction we're talking about. And then it conducts retrogradely, or backward, back up to the atria via the normal His-Purkinje system in the AV node. Or rarely it might even use a second accessory pathway for that retrograde limb.
So the loop is reversed compared to orthodromic.
Exactly. Down the AP, up the normal system. The key ECG signature here is a wide QRS complex. This wide QRS is produced entirely, or almost entirely, by ventricular excitation traveling over the accessory pathway because there's little or no contribution from the more rapidly conducting specialized His-Purkinje fibers. The electrical impulse spreads slowly, inefficiently, and directly through the ordinary ventricular muscle from where the AP inserts, resulting in that broad, often bizarre-looking QRS.
And that sounds like it could look like VT.
Precisely. This wide complex tachycardia, antidromic AVRT, is often indistinguishable from monomorphic ventricular tachycardia, VT, just looking at the surface ECG. And that's a critically important point because VT is a very dangerous, potentially lethal arrhythmia originating from the ventricles themselves, often requiring immediate intervention like cardioversion or specific antiarrhythmics. So the rule always is, a wide QRS complex tachycardia must always be presumed to be VT until definitively proven otherwise. Treating VT as if it were a benign SVT can have catastrophic consequences.
Is there any clue it might be antidromic AVRT?
The biggest clue is the patient's baseline ECG when they're not in tachycardia. The presence of pre-excitation in sinus rhythm, meaning a delta wave and short PR interval when the patient is in normal rhythm, is a critical clue that strongly suggests antidromic AVRT as the likely diagnosis for their wide complex tachycardia. Without that pre-excitation visible in normal rhythm, distinguishing antidromic AVRT from VT based on the surface ECG alone is extremely difficult, often impossible without an invasive study.
Okay, what about when the accessory pathway is just a bystander during another arrhythmia? It's not part of the primary circuit, but it's still involved and can cause, as you hinted, incredibly severe problems, especially with atrial fibrillation. What makes pre-excited AF so much more dangerous than typical AF or even other pre-excited tachycardias? This feels like a critical aha moment for clinicians.
It really is. This is probably one of the most critical concepts to grasp regarding accessory pathways, and yes, understanding this is a true aha moment that can absolutely save lives. Bystander accessory pathway conduction. This occurs when an accessory pathway simply allows antegrade conduction down to the ventricles during another independently occurring arrhythmia originating in the atria. This could be during an atrial tachycardia, atrial flutter, or most notoriously and dangerously, atrial fibrillation, AF. It could even happen during AVNRT sometimes. The accessory pathway isn't part of the primary re-entry circuit that's generating the atrial arrhythmia. It's just acting like an open gate, a side door that happens to be conducting those rapid atrial impulses down to the ventricles.
And it conducts them faster than the AV node would allow.
Potentially much, much faster. And you're absolutely right, pre-excited atrial fibrillation, AF, and sometimes pre-excited atrial flutter are potentially life-threatening arrhythmias precisely because the accessory pathway might allow very rapid and repetitive conduction from the chaotically firing atria directly to the ventricles. This is the scenario that electrophysiologists and emergency physicians dread most when dealing with accessory pathways. There's even a specific risk threshold that's fascinating and crucial. Research shows that approximately 25% of accessory pathways that cause pre-excitation on the baseline ECG can conduct impulses so rapidly during induced AF that the minimum R-to-R interval, the shortest time between consecutive ventricular beats, is less than 250 milliseconds.
Less than a quarter of a second between beats. That's incredibly fast.
Dangerously fast. That corresponds to ventricular rates potentially exceeding 240, even 300 beats per minute. And these pathways with very short refractory periods allowing these rapid rates are strongly associated with a higher risk of inducing ventricular fibrillation and sudden death.
Why? What happens electrically?
Because the accessory pathway conducts impulses so rapidly and directly to the ventricles, the ventricular muscle simply doesn't have enough time to fully repolarize to electrically reset itself between beats. This creates electrical chaos, heterogeneity of refractoriness in the ventricles, which can easily degenerate into ventricular fibrillation, that quivering, non-pumping state, which is an immediate lethal rhythm unless corrected instantly. Clinically, pre-excited AF presents as a wide, complex, very irregular rhythm on the ECG. It's irregular because the underlying rhythm is atrial fibrillation, and it's wide because of the pre-excitation via the accessory pathway. The ventricular rate is determined by the conduction properties of both the accessory pathway and the normal AV node, and their chaotic interplay leads to this very fast, irregular, and often bizarre-looking rhythm. The QRS complex itself can look quite strange and even change its shape dramatically from beat to beat. This is due to the variability in the degree of fusion, how much the ventricle is activated via the AV node versus the AP. Sometimes it's mostly AV nodes, sometimes mostly AP, often a mix. Or sometimes almost all beats might conduct entirely down the accessory pathway, leading to those extremely rapid rates far beyond what the AV node would normally allow.
Okay, now here's the crucial part you mentioned earlier, the danger with certain medications.
Yes, the dangerous paradox. This is a really important detail that every clinician must absolutely ingrain. Paradoxically, while the normal Purkinje system activating the ventricular end of the accessory pathway can sometimes prevent the atrial wavefront from conducting over the AP, slowing AV nodal conduction with medications without simultaneously slowing accessory pathway conduction can thereby facilitate accessory pathway conduction and dangerously accelerate the ventricular rate.
So blocking the normal path forces more traffic down the dangerous bypass.
Exactly. You give medications that slow down the normal AV node pathway, effectively removing its traffic control and its competition for activating the ventricles, and you're essentially forcing more of those rapid, chaotic atrial impulses down the uncontrolled accessory pathway. This leads to an even faster and more dangerous ventricular rate, potentially pushing the patient directly into ventricular fibrillation. Because of this critical life-threatening risk, the administration of standard AV nodal blocking agents is absolutely contraindicated during known or suspected pre-excited AF or flutter. This includes common medications like oral or intravenous verapamil, diltiazem, calcium channel blockers, beta blockers, intravenous adenosine, and even intravenous amiodarone, which can sometimes slow the AV node before it affects the AP.
Wow, so the standard drugs for regular SVT are out.
Completely out. Giving any of these medications in this specific scenario would slow the normal AV node pathway, remove its protective filtering effect, allow the accessory pathway to conduct impulses unchecked at extremely rapid rates, and could potentially lead directly to ventricular fibrillation and sudden cardiac arrest. This is a life or death decision point. So, given this immediate danger, the acute treatment for rapid pre-excited tachycardia, especially if it's irregular and wide, is immediate electrical cardioversion. That synchronized shock is often the fastest and safest approach to reset the rhythm. If cardioversion isn't immediately feasible, or perhaps as an alternative in some more stable, though still urgent cases, intravenous procainamide or sometimes ebutylide may be used. These medications work differently. They directly slow conduction in the accessory pathway itself. This may either terminate the arrhythmia or at least slow the ventricular rate down to a safer level, buying time and stabilizing the patient.
So with all this complexity of different types of AVRT, the bystander pathways, the VT mimics, the critical drug contraindications, what does this all mean for the comprehensive long-term management of patients who are found to have these accessory pathways, especially those diagnosed with WPW syndrome? It seems like a very precise and multifaceted approach is needed.
Indeed, it's a comprehensive management strategy that really requires careful consideration and personalization for each patient based on their specific pathway, symptoms, and risk profile. The initial management of orthodromic AV reentry, that common narrow complex tachycardia we discussed, is largely covered under the general approach to PSVT, which we'll detail next regarding acute treatment. However, for patients with a WPW syndrome who present with any kind of wide complex tachycardia, whether it's suspected antidromic AV reentry, orthodromic AVRT with a pre-existing bundle branch block making it look wide, or a truly pre-excited tachycardia like AF or flutters, the treatment strategy hinges critically on accurately identifying the underlying rhythm and its specific characteristics, always keeping that life-threatening potential in mind. Initial patient evaluation should always include a thorough assessment for any aggravating factors that might trigger or worsen arrhythmias. Things like intercurrent illness, maybe an infection, or factors that increase sympathetic tone, severe stress, stimulant use, certain medications. A thorough physical examination should also focus on excluding any underlying structural heart disease. Remember those associations.
Right, like Epstein's or hypertrophic cardiomyopathy.
Exactly. So an echocardiogram, an ultrasound of the heart, is very reasonable, often essential, to rule out conditions like Epstein's anomaly or those specific forms of hypertrophic cardiomyopathy that can be associated with accessory pathways. Finding one of those would significantly alter the overall management plan and risk assessment.
What about patients who definitely have pre-excitation on their baseline ECG and are also experiencing symptoms of arrhythmia? Not just palpitations, but documented tachycardia episodes. This sounds like a particularly higher-risk group that demands very close attention.
You're absolutely right to identify them as high risk. This is a significant group. Patients with manifest pre-excitation on their ECG who also have symptoms of arrhythmia are considered to be at significant risk for developing atrial fibrillation. And with that, as we just hammered home, comes the heightened, albeit still relatively rare overall, risk of sudden death, particularly if they happen to have one of those accessory pathways that allows for dangerously rapid antegrade conduction during AF. The estimated risk of sudden cardiac arrest in this symptomatic adult WPW population is thought to be in the range of 2 per 1,000 patients per year. Still small, but definitely not negligible. And critically, it's likely even greater in children with symptomatic WPW, perhaps as high as 2 to 4 per 1,000 patient years. That's a non-trivial risk that absolutely warrants proactive investigation and management.
So what's the next step for them?
Because of this demonstrable risk, an invasive electrophysiology study, or EP study, is strongly recommended for virtually all symptomatic patients with WPW. This study allows electrophysiologists to precisely map the heart's electrical pathways by placing specialized catheters inside the heart chambers. Crucially, it allows them to directly test the accessory pathway's properties. How fast can it conduct forward? How quickly does it recover? Can it sustain those dangerously rapid heart rates if atrial fibrillation were to occur? We essentially try to induce AF safely in the lab to see what the pathway does. This definitively stratifies the patient's risk.
And you can treat it at the same time.
That's the major advantage. This EP study is usually combined with potentially curative catheter ablation in the very same procedure. If a risky pathway is identified, or even a pathway causing bothersome symptoms, it can often be eliminated right then and there. So, catheter ablation is definitely warranted for patients with WPW and recurrent arrhythmias, especially when drug therapies are ineffective, not tolerated, or simply not desired by the patient who prefers a definitive cure and removal of that sudden death risk. The efficacy of catheter ablation for accessory pathways is remarkably high, often in the range of 95% cure rate, though success can vary slightly depending on the specific anatomical location. Some spots are trickier than others, and the complexity of the pathway.
What about the risks of the ablation itself?
Good question. While generally safe and highly effective, it's important patients understand that serious complications can occur, although infrequently, maybe in less than 3% of patients overall. These can include significant issues like causing complete AV block if the ablation near the normal system damages it, potentially requiring a permanent pacemaker, or cardiac tamponade where fluid builds up rapidly around the heart due to a small perforation. Other risks include thromboembolism or blood clots forming on the catheters that could lead to stroke. Rarely, coronary artery injury if an artery runs close to the ablation site, and various vascular access complications at the groin where the catheters are inserted. However, it's reassuring to know that the risk of procedure-related mortality, death from the procedure, is exceedingly low, typically less than 1 in 1,000 patients. So, while risks exist, the benefits of potentially curing the arrhythmia and, crucially, eliminating the risk of sudden death often decisively outweigh them for most symptomatic WPW patients.
Can we use simpler, non-invasive tests, like an exercise stress test or maybe a Holter monitor, to assess the risk of these pathways? Perhaps to avoid an invasive EP study for everyone?
That's a common question. While ambulatory monitoring, like a Holter monitor worn for 24 or 48 hours, or an exercise stress test, is often used to try and gain some reassurance that an accessory pathway might not be high risk. For example, by looking for abrupt loss of the delta wave, abrupt loss of pre-excitation at physiologic heart rates during exercise. It's not completely reliable for definitive risk stratification. It can give false reassurance.
Why isn't it reliable?
Well, for instance, seeing a gradual loss of accessory pathway conduction with increased sympathetic tone during exercise does not reliably indicate low risk. This can occur simply because, as we said, the normal AV nodal conduction speeds up during exercise and effectively outcompetes the AP for activating the ventricle, making the delta wave disappear on the ECG. It doesn't necessarily mean the AP couldn't conduct rapidly if faced with something like AF. Therefore, the possibility of rapid antegrade accessory pathway conduction during AF is not definitively excluded by these non-invasive tests. An EP study provides a much more definitive, direct, and controllable assessment of the pathway's intrinsic properties under various induced conditions, including pacing at very rapid rates to simulate AF.
Okay, that makes sense. What about those patients with concealed accessory pathways, the backward-only ones, or maybe those with known low-risk APs that only cause orthodromic AVRT, the narrow complex kind, and don't show pre-excitation? What's the chronic management approach for them?
Their risk profile seems quite different. Exactly. For these patients, where the risk of sudden death from pre-excited AF is essentially zero because the pathway doesn't conduct forward or is known to be very low risk based on EP study. Chronic therapy is guided primarily by their symptoms and the frequency of their orthodromic AVRT episodes. It's much more like the approach for AVNRT. Vagal maneuvers might terminate episodes for some, as can a single dose of a beta blocker, verapamil, or diltiazem taken orally right at the onset of an episode, that pill-in-the-pocket approach we mentioned.
So they carry the pill with them.
Yeah, they carry it with them and take it only if an episode starts and doesn't stop with vagals. For ongoing management to reduce the frequency of episodes, chronic daily therapy with these same agents, beta blockers or calcium channel blockers, or sometimes flecainide, can be effective in some patients. The choice really depends on patient tolerance, any coexisting medical conditions, potential side effect profiles, and patient preference. The key goal here is symptom control and improving quality of life rather than risk reduction. Ablation is also an option for symptom control if desired.
What if someone is found to have pre-excitation on their ECG, the short PR, the delta wave, but they have absolutely no arrhythmia symptoms at all? They feel perfectly fine. This must be a common scenario given the prevalence of APs. And it raises a lot of questions about how to manage them, right? Do you treat them? Do you just watch them?
This is indeed a very common scenario and a frequent point of discussion and sometimes debate in cardiology, the management of the asymptomatic WPW patient. Adults who have manifest pre-excitation on their ECG but report absolutely no arrhythmia symptoms at all still carry a lower, but still present, risk of sudden death compared to the general population. This risk is estimated to be about 1 per 1,000 patient years. So over 10 years, maybe 1% risk, small but not zero. Children with asymptomatic WPW are generally considered to be at a somewhat greater risk, maybe around 2 per 1,000 patient years.
So what do you do? EP study for everyone?
Not necessarily. For certain individuals, an electrophysiology study is usually advised even if they're asymptomatic. This applies particularly to people in occupations where even a brief, non-lethal arrhythmia occurrence could place themselves or others at great risk. Think commercial pilots, bus drivers, train operators, heavy machinery operators, maybe some competitive athletes in high-risk sports.
High-risk profession.
Exactly. In these professions, the potential consequences of even a brief syncopal spell or incapacitating tachycardia are just too high. For most other asymptomatic individuals without high-risk occupations, routine clinical follow-up without aggressive therapy or prophylactic ablation is generally considered a reasonable option. This involves making sure they are fully educated about the potential symptoms to watch for, palpitations, dizziness, fainting, and understand the very small but present lifetime risk. It always comes down to balancing that small but real risk against the invasiveness and the small but real risks of an EP study and ablation procedure. Patient preference, lifestyle, anxiety level, and overall risk tolerance also play a significant role in that shared decision-making process between the patient and their doctor. There's no single right answer for everyone.
So we've covered the different types of PSVTs, dissected the mechanisms like AVNRT loops and accessory pathways, and explored the complex long-term management strategies, especially for WPW. Now let's bring it all back to the immediate situation. If someone presents to an emergency department, or maybe their doctor's office, with an acute PSVT episode happening right now, what's the immediate acute management plan? What's the protocol clinicians follow step by step?
Right, the acute management. It's guided entirely by the clinical presentation, how the patient looks, what their vital signs are, and crucially, their hemodynamic stability. First and foremost, continuous ECG monitoring should be immediately implemented. Get them on a monitor so you can see the rhythm in real time. This gives you an immediate visual of the heart's electrical activity and lets you see if your interventions are working. Additionally, a full 12-lead ECG should always be obtained as quickly as possible, ideally during the tachycardia if possible, but definitely right after if it starts. This comprehensive electrical snapshot is absolutely crucial for helping determine the underlying mechanism of the tachycardia. It provides those critical clues we discussed earlier: narrow versus wide, QRS, P-wave location and morphology, regularity that help differentiate one type of PSVT from another, or from VT. This full picture helps guide the subsequent treatment decisions.
What if the patient is unstable? What precisely defines instability in this context, and what's the immediate rapid response required? Things need to happen fast, right?
Absolutely. And the presence of hemodynamic instability, and that's generally defined by significant symptoms directly related to the fast heart rate, like profound hypotension leading to unconsciousness or severe altered mental status, signs of shock like cool, clammy skin, acute heart failure with respiratory distress, or ongoing ischemic chest pain. Then, immediate QRS synchronous direct current cardioversion is warranted.
The electrical shock.
Yes, delivering a controlled electrical shock to the chest, synchronized to the R wave of the Q or S complex on the monitor to immediately reset the heart's rhythm. This is a life-saving intervention in unstable tachycardia. However, in practice, this is rarely needed for most narrow QRS PSVTs because, as we'll discuss, intravenous adenosine works remarkably promptly and effectively in the vast majority of these situations. It often terminates the arrhythmia before cardioversion becomes necessary, and it has fewer immediate risks like needing sedation. But you must be ready to cardiovert if needed.
Okay, so for the stable patients, the ones who are conscious, talking, not in immediate distress, but clearly having a rapid heart rate, where do we start? What's the first line of defense?
For stable individuals with narrow complex PSVT, the initial therapy takes advantage of that fundamental fact we keep coming back to. Most common PSVTs, like AVNRT and orthodromic AVRT, are dependent on AV nodal conduction. Therefore, they are highly likely to respond to sympatholytic maneuvers, things that reduce sympathetic tone, and vagatonic drugs, or maneuvers things that increase vagal tone. Both approaches aim to slow down or block conduction through the AV node.
Targeting the weak link.
Targeting the weak link in the circuit, exactly. As these maneuvers or drugs are administered, the ECG should be continuously recorded, ideally with a strip running, because the patient's response can provide crucial diagnostic information. For instance, if you give adenosine or do a vagal maneuver and you see transient AV block develop, but the tachycardia continues in the atria, you see ongoing rapid P waves marching through, that's a strong indicator you're dealing with an atrial tachycardia or atrial flutter, not an AV nodal-dependent rhythm like AVNRT or AVRT. It's a diagnostic maneuver as much as a therapeutic one.
Let's talk more about those vagal maneuvers. What are they and how should they be performed effectively by a patient or a clinician?
Right. Vagal maneuvers are often the first step because they're non-pharmacological, can be done quickly at the bedside, and have virtually no serious side effects if performed correctly in the right patient. Carotid sinus massage is a reasonable option, but it needs caution. It should only be done if the risk of underlying carotid artery disease is low, meaning you listen first and hear no carotid bruits and the patient has no prior history of stroke or TIA. You wouldn't want to dislodge plaque. If performed, it involves gently but firmly massaging the carotid sinus area in the neck, typically just below the angle of the jaw, usually on one side at a time for 5–10 seconds while monitoring the ECG. This stimulates baroreceptors there, which in turn stimulates the vagus nerve, potentially slowing AV conduction enough to break the tachycardia.
What about the Valsalva? That seems more common.
It is more common and generally safer. The Valsalva maneuver should be attempted in cooperative individuals. The standard way is for the patient to take a deep breath and then exhale forcefully against a closed glottis, like straining hard during a bowel movement or trying to blow up a very stiff balloon for about 10–15 seconds. This significantly increases pressure inside the chest, which activates those vagal reflexes. If it works, the patient can then be taught to perform this maneuver themselves as needed for future episodes, giving them that immediate self-management tool. There are also modified Valsalva techniques, like having the patient strain while semi-recumbent and then immediately lying flat and having their legs raised by an assistant, which some studies suggest might be even more effective.
And if vagal maneuvers don't work or can't be done, what's next in the acute treatment algorithm? It sounds like adenosine is the big gun here.
Yeah, if vagal maneuvers fail or can't be performed, intravenous adenosine is highly effective and usually the very next step in the algorithm for stable, narrow QRS PSVTs. Adenosine will terminate the vast majority, often over 90% of PSVT episodes caused by AVNRT or orthodromic AVRT. It works by transiently blocking conduction in the AV node, usually for just a few seconds. It has an extremely short half-life, measured in mere seconds, meaning its effects wear off incredibly quickly. This makes it an ideal diagnostic and therapeutic agent for these AV nodal-dependent rhythms. It's given as a rapid IV push, usually 6 mg initially, followed by 12 mg if needed.
What about side effects? You mentioned it can feel unpleasant.
Yes, it's not pleasant for the patient, though it's very brief. Patients often experience a sudden feeling of transient chest pain or pressure, dyspnea or shortness of breath, a feeling of flushing or warmth, and often significant anxiety, sometimes described as a sudden rush of dread or impending doom. These sensations are usually very intense but last only seconds, maybe 10–20 seconds max, as the drug is metabolized almost instantly by enzymes in the blood and tissues. It's important to warn the patient what to expect. There are also important contraindications and cautions. It's absolutely contraindicated in patients with prior cardiac transplantation because their denervated hearts can be hypersensitive to adenosine, leading to prolonged AV block. It can also theoretically aggravate bronchospasm, so caution is needed in patients with active asthma or severe COPD. And most crucially, repeating this critical point, adenosine is known to precipitate atrial fibrillation, usually briefly, in up to 15% of patients receiving it. Because of that inherent life-threatening risk we discussed with pre-excited AF, adenosine should be used very cautiously, if at all, and only if resuscitation equipment is immediately available in patients with known or suspected Wolff-Parkinson-White syndrome, where the induced AF could potentially produce severe hemodynamic instability and degenerate into VF. That's a huge caveat.
Okay, crucial caution there. What about other medications like IV beta blockers or calcium channel blockers? Are they used in the acute setting, or are they more for long-term management?
Yes, intravenous beta blockers like metoprolol or esmol and non-dihydropyridine calcium channel blockers, specifically verapamil or diltiazem, are also effective in terminating PSVT. They work by similar mechanisms to adenosine, primarily by slowing AV nodal conduction. However, they have some important drawbacks compared to adenosine in the acute setting for initial termination. They may cause hypotension both before and especially after the arrhythmia terminates, which can be problematic if the patient's blood pressure is already borderline. And importantly, they have a significantly longer duration of action compared to adenosine's rapid metabolism. Their effects last minutes to hours. This means if an adverse effect like prolonged hypotension or significant bradycardia occurs, it will persist for much longer, potentially requiring more sustained intervention. Because of this, adenosine is generally preferred for the initial attempt at termination in stable, narrow, complex PSVT. For calcium channel blockers or beta blockers might be considered second line if adenosine fails or is contraindicated, or perhaps used later for rate control if the rhythm turns out to be something like atrial flutter or AF. These agents can also, as we mentioned, be given orally for longer-term prevention or used in that pill-in-the-pocket approach for patients to take themselves on an as-needed basis to slow the ventricular rate and maybe facilitate termination by Valsalva.
Now, what if the tachycardia is wide complex on the ECG? This seems like the trickiest and potentially much more dangerous scenario, given everything we discussed earlier about ventricular tachycardia and pre-excited rhythms. This is where clinical decision-making becomes incredibly precise, or maybe dangerously imprecise if not handled carefully.
You're absolutely right. This is arguably the most challenging and potentially dangerous acute arrhythmia scenario a clinician faces in the ER or clinic. The differential diagnosis of a regular or irregular wide complex tachycardia is broad and includes potentially lethal rhythms. It includes life-threatening ventricular tachycardia, VT, which is the most common cause of wide complex tachycardia in adults. It includes PSVT with bundle branch block aberrancy, meaning a narrow complex PSVT like AVNRT or AVRT that just happens to have an underlying or rate-related bundle branch block pattern widening the QRS. And it includes those pre-excited tachycardias we discussed, like antihydromic AVRT or pre-excited AF flutter, where the accessory pathway is involved in the wide QRS. The general and critically important safety rule here is wide complex tachycardia should be managed as ventricular tachycardia until proven otherwise, especially in older patients or those with known heart disease, because VT is often life-threatening and requires immediate specific treatment. You do not want to mistakenly treat a lethal VT with the wrong drug, like verapamil, which can be deadly in VT.
So assume VT first, but are there nuances?
Yes, there are crucial nuances based on regularity and stability. If the wide complex tachycardia is regular and the patient is hemodynamically stable, meaning no severe symptoms, good blood pressure, a trial of intravenous adenosine is reasonable, especially if the patient is young and has no known heart disease. Why? Because some regular wide complex tachycardias are indeed PSVTs with aberrancy or rarely antidromic AVRT, and adenosine will often terminate them safely, which also helps confirm the diagnosis. If adenosine does nothing or only briefly slows it, then it's highly likely to be VT, and the clinician must immediately shift to VT-specific treatments, like amiodarone, procainamide, or cardioversion. If, however, the wide complex tachycardia is very irregular, that immediately raises a huge red flag and demands urgent, specific action. It is most likely pre-excited AF or flutter conducting rapidly over an accessory pathway.
The dangerous one.
The really dangerous one. As we detailed, this is a critical, high-risk situation that can degenerate rapidly into ventricular fibrillation. In this specific case, it should be managed urgently with immediate electrical cardioversion if the patient is unstable at all. If they seem transiently stable, intravenous procainamide or abutolide can be considered, as these medications directly slow the accessory pathway. Avoid AV nodal blockers at all costs. Now, if the diagnosis of PSVT with aberrancy is absolutely unequivocal, for example, in a patient with multiple prior documented episodes of the exact same wide complex tachycardia that was proven to be SVT with aberrancy in an EP study, and their baseline ECG shows the same bundle branch block, then treatment for PSVT with vagal manoeuvres and adenosine might be reasonable. But that requires absolute certainty, which is rare in the acute setting. In all cases of tachycardia, whether narrow or wide complex, stable or unstable, continuous ECG monitoring should be implemented without delay, and emergency cardioversion and defibrillation equipment should always be readily available and immediately at hand. Preparedness and rapid access to life-saving tools are absolutely key, as conditions can change very rapidly in these cardiac emergencies.
Wow. What an incredible journey into the heart's hidden electrical pathways and the strategies to manage them when they go haywire. From the subtle loops of AVNRT causing those pseudo-S waves and that unique Canada wave sensation, to the intricate detours of accessory pathways in WPW, leading to orthodromic and antidromic AVRT, and especially understanding the critical dangers and absolute contraindications in managing pre-excited AF. We've truly gone on a deep dive today.
We certainly have, and we've seen how mastering these details, really understanding the specific electrical mechanisms, recognizing those nuanced ECG signatures, knowing the precise management algorithms, including those critical contraindications like avoiding standard AV nodal blockers in pre-excited AF, is what truly sets apart the elite professionals in this field. It's not just about memorizing the names of the rhythms, right? It's about genuinely grasping how they work electrically, how they manifest clinically in a patient, and what that means for that patient's immediate safety and their long-term health and treatment plan. It's about connecting those sometimes abstract electrophysiological dots to real-world, potentially life-saving clinical impact.
So, after diving this deep into the intricacies of these tiny, often congenital electrical detours and loops, what stands out to you is maybe the most surprising or counterintuitive detail about how these electrical circuits can have such a profound and sometimes life-threatening impact on the entire body. And thinking about how precisely we need to distinguish these rhythms based on subtle clues. How might this newfound depth of understanding reshape your perception, or our listeners' perception, of seemingly simple heart palpitations the next time you or someone you know experiences them? It makes you think differently, doesn't it? Thank you for joining us on this deep dive into paroxysmal supraventricular tachycardias. We hope you feel more than just informed. We hope you feel truly empowered with a new level of understanding of these complex and critical cardiac arrhythmias, maybe even closer to that expert mastery we aim for. Until next time, keep exploring, keep questioning, and keep diving deep.